All right, everybody. We are going to start with the case panel discussions, and all the speakers who were in the prior session, if you guys could come up. So Mike Kelly, Lee Tan, Munish, Coy, Steve, and Joe. So Mo, you want to come up? So we're going to present 4 different cases. If we can get to all 4 of them, it would be nice. And this is mainly just to be interactive and pick people's brains of how they would address these common pathologies. We're going to have one of our current spine fellows who's coming up to us from Canada, the Vancouver group, talk to us first about posterior-only approaches for de novo flat back. So go ahead, Mo.
Thank you. Thanks for having me, Dr. Geologist. So the case I'll be presenting to you titled Posterior-Only Approach for De Novo Flat Back Deformity. So history, 76-year-old male presents with chronic worsening lower back pain greater than bilateral leg pain to the L3. Pain has been present while standing for less than 10 minutes and affects all aspects of his life. Past medical history, significant for paroxysmal SVT on heart monitor, ischemic CVA in 2023, with a TPA window involved the left corona radiata, precentral dryness with a right upper extremity weakness, bilateral renal artery stenosis, AAA, active smoker. So moving on, physical exam, he has a stooped forward gait, head forward position. Motors are 5 out of 5 on all myotomes with the exception of his right L4, TA4+, and baseline right upper extremity CVA deficits, which has been noted due to his history. Sensory is normal, reflex is normal. Other than that, he also has an antalgic gait, but he's able to do a tandem gait. As for imaging, these are his pre-op radiograph, AP and lateral, and these are supine radiographs as well. And as for parameters and overall appearance, it appears he has a positive sagittal imbalance. SVA measured 33 centimeters, quite high, which is actually passively correctable, as you can see from the supine films. Largely misaligned from a hypolordotic lumbar spine, PI 50, LL 3 degrees, L4S1 0 degrees, with a mismatched PILL. Incompletely compensated through the pelvis, pelvic tilt being 28, but not through the thoracic spine, T4 to 12 is 50 degrees. Coronally, there's a left trunk shift imbalance as well, 5.5 centimeters, and there's some lumbar degenerative scoliosis that would kind of fit into an ovoid 1A2 or a bow B. So the concavity is driven, not a lumbosacral driven curve. Otherwise, the right and left shoulders and pelvises are equal. These are MRI scans, sagittal imaging here. At L1, 2, you can see some stenosis, 2, 3, 2, 3, even more, 3, 4, and so on. This is a CT lumbar spine. Again, based on previous talks, you can appreciate the predominantly ankylosed spine anteriorly. And this is the angulation here, 13 degrees. So with that being said, what would be a good plan? So, oh yeah, sorry, I don't want to give you the answer.
Is he on blood thinners?
Not presently. I believe just aspirin.
Yeah. And has he been fitted with a beautiful custom walker?
I was going to say, have you ever seen Caddyshack?
No, what is that?
There's a part, what's that? Oh my God. There's a part where Bill Murray's character comes in, he's talking to Chevy Chase, and Chevy Chase says, we have a pool and a pond. Pond's good for you. With this guy's history, the real kicker of the history is smoking.
Yeah.
Until the smoking is not smoking and you have a negative urine cotinine, right, which hangs along longer than a blood nicotine test, this guy gets a pretty souped up walker in my practice, as Dr. Lewis just said. because the failure, it's never good when the aorta is highlighted for, the only thing worse than that, I think, is when the aorta looks like a prime source of bone graft. This patient is super, super high risk. And a little bit, I got a little bit from Dr. Gupta, where Gupta was doing very big surgeries on decrepit people, because people, they deserve a chance. And Raj isn't here, but like people, we're in the United States, you have pain, I think I can help your pain. I will do a big surgery to you, but you need to take ownership of your comorbid conditions that we can't control. I can't control this guy's aorta and his brain, but the fact that he's smoking is a non-starter in my practice, and I think in probably most practices up here on the panel.
Yeah, I would completely agree. The history, I'm not doing surgery on this patient, probably ever, but if we were to take away the history and say he was a non-smoker and we're just purely treating radiographs for the sake of going through what the prior lectures were, he's flat from 4 to 1, looks like he's fused, and so he's going to need more distal lumbar lordosis. So I would do a 3-column osteotomy through the L4 segment. He's going to need a decompression at those 2 levels where he's stenotic. He's quite flexible if you look at the left images versus the supine, but because of his trabecular uncovering that he has, I think his bone density is probably poor, and that kyphosis that he has in the mid-lumbar spine, I think will ultimately cause an early failure of a lower thoracic to pelvis reconstruction. So I think this is someone that I would probably go upper thoracic to pelvis with an L4 PSO if he wasn't as sick as he is.
I think for me, it'd be interesting to tease out, how much of his symptoms and how much of his standing alignment is due to claudication. He's really tight at 2-3 and 3-4. He's a medical train wreck, right? But if he says, I'd rather prefer, a 2-hour surgery with a little tiny incision. I'm happy if my leg pain goes away, even if I still have, bad back pain. That's something that you can offer for this patient where, much lower risk than upper thoracic to pelvis, which I agree is probably the way that this person's alignment would be treated.
The problem I have with that approach is that I think back to I think back to a residency M&M where we had some metastatic disease patient and said something, and Sig Bervin said, "Look, I don't have a crystal ball. I don't know how long this person's going to live. I don't know why you're asking me that." And I don't think that those keep the flat back, decompress the nerve are durable surgeries. And I also don't think in high volume 3-column osteotomy practices, maybe I'm crazy, but I didn't think that the morbidity in my hands was what it was said to be. I think we had a good team. We could do it quickly. So I just don't love those surgeries where your outcome horizon is first follow-up visit 1 year, 2 years. I think that is woefully insufficient. But I don't know what the right answer is. That's the problem. I just have my preference. And for this one, given the vacuum and all that sclerosis in 3-4 and the nice large shape of L5, with a PI of 50, I would do it L5 PSO, and I would do it extended, I would do it like a Lamartina corner osteotomy, also almost cutting out where you get the dashes there, so that I could drop a block of L4 into that block of L5 and maintain the anterior column and have a nearly 100% fusion rate for the PSO.
And push back on that a little bit. That used to be what we all said when we were trying to be, really virtuous and say, okay, we're not going to operate on these. I wouldn't touch this patient if they were smoking a cigarette, and I'm going to, interrogate their urine with 3 or 4 tests to see if they're lying to me and all this, But in practice, I want to be the devil's advocate here and say, okay, if you use multiple rods, you use double pelvis, you use multiple rods, you use negative pressure, maybe wound drainage, you use some of these modern wound coverings. Do we really see these older patients failing in terrible pseudoarthrosis with rod fracture anymore with our current rod strategies. If we use tethers for PJF, we use negative pressure wound drainage, we use collagen, we use these multiple rods. So it should, and they can pass a pulmonary evaluation. They're not compromised from a pulmonary standpoint. Do we really have to say absolutely, zero smoking anymore? Because in Europe, they do these cases while they're smoking. And then we have BMP. I mean, what do you guys think about that?
When I was a resident, I worked on vascular surgery. I ended up doing 6 months of vascular surgery, and the staff I worked with said, I'm never going to operate on a smoker. And then he said after 3 months, I had no cases to do. So he changed his philosophy after. And I mean, there's true. I don't think this guy's life or death. I think he'll do fine with a walker, and I don't feel pressured to do any surgery on this guy at all. I don't think it's ridiculous to do a decompression, as you say. I think, and because it's probably better than the outcome of a long fusion on a guy like this. But I don't see an emergency T10 to pelvis with an osteotomy that's needed for this guy. So I don't think, I agree that the smoking, but I think he's got enough comorbidities. I'm sure he's on blood thinners, which makes it very complicated to come through a surgery like this. And it's probably something that I just probably wouldn't undertake just because I don't think the outcomes are going to be, the chance of great outcome are that great.
Can I make a comment quick? So I would like to make a recommendation to the panel members. So if you need your neck massage after this panel discussion, talk to Alekos and Aaron. Book your, massage, neck massage. If you need surgery, Lee Tan and Bobby Tay is here. They can make you a really good recommendation. Maybe next discussion, you can come downstairs. Actually, I can see that it's really, really hard for you guys to look at the cases.
So, Chris, I don't know if you guys know the Japanese surgeons, Nomubasa Suzuki. I remember him from many, many years ago. He said, if I don't operate on smokers, I have no patients, because in Japan, everybody was smoking. So there's some truth to what you're saying. And Art Steffi used to say there's piano players and there's concert pianists. Some of it is technique. And so there's some truth to that. We just don't have data, and all the data that we have, smoking, you don't fuse. And the failures I've had personally have been smokers. So there's some validity to that just in my personal thing. But if I were to comment on this case, I can tell you, being a big anterior proponent, the anterior is not enough in this case. And the two comments I want to make is, one, when they're so far off, coronally and sagittally, it's better to go higher than lower, because there's so much, I call it spinal inertia. The spine is like this, you pull them back to here, they want to go back. So they will fail more often if you stop short. And the other comment is, I think some of the panel members commented, there's some sort of sagittal plane, not just from the deformity, but also from the stenosis. Because then they lean forward, they're relieving that stenosis. Mm-hmm. So those are my comments.
What do you think about an undercorrected upper thoracic to pelvis? Because I don't think that's a good option.
No, I think if you're gonna do it, you gotta do the shebang.
Mm-hmm.
Yeah, Chris, it's been a while since I've looked at the literature, but the last time I did on this subject, I think what I found was, one level ACDFs and one level lumbar fusions. Maybe it's okay if they keep smoking. I agree. Otherwise, I agree with Mike. If they come in and they tell me they're smoking, they have to quit and they have to prove it. I'm not sure if others do the same.
Even if they have, I'll give it up after this. Even if they have a couple levels pseudo, they're not going to break their rods anymore the way they break their rods in the short term. Patients not going to live 30 more years for sure. They're not going to break their rods. We tether them at the top, so even if the hook comes a little bit loose, they still tether up there. We use negative pressure drainage for their wound. My gosh, negative pressure drainage is a big deal on chemo therapy. I mean, I just don't think. I think what we say about smoking is true to some extent, certainly the higher risk group. But with modern technique, I feel like we've changed that risk profile a bit, and yet the reflex answer is always no. And that's smoking I would never do. And it's not true in Japan, it's not true in Europe.
I think you're absolutely right that there is, like Manish said, the truth is probably somewhere in the middle. but you made the comment just right there. This person's not going to live till 30. As we're trying to justify these longer constructs that we're all doing, and we're still seeing high failure rates, the person who's in their 60s or 70s, who's a smoker like this, who's not going to live until their 90s, it's going to look tough when we're doing a very costly surgery and then they're dying 5 years later from a stroke. And so I think there has to be a balance. This person probably is on the extreme end of smoking, but I do think, like you're saying, with modern techniques, you can get away with it for sure.
My question is, if you decide to go forward with the with surgical intervention, how do you optimize the bone quality, and what's sort of your thoughts at that point? Do you, because I've been fooled many times by folks just like this. I'm not always operating on folks like this, where either the bone is better than what I thought it was going to be when I get in there, or the bone is much worse than I thought they were going to be. And what's the strategies if you guys decide to do surgical intervention?
That's an easy one. So don't rely on bone density from the spine, because they'll show you that first. Rely on hips and wrists. So, and if they're osteoporotic, you put them on anabolics, and at least for 3 months. And there's actually now literature by Zishan from New York saying that if you do that, your results are as good. So I think screening, it's amazing. Did you know that I'm vitamin D deficient with my skin color? Because I live inside the OR or the clinic. So I think that, we are very under prepared for these things. So, you have to look for vitamin D deficiency, you have to look for osteoporosis, and you optimize them with anabolics. And that has really changed things more than anything else. So 3 months and then up to a year afterwards.
Mm-hmm. I think that I follow that same regimen. The place where I feel like there's a challenge is the people who are right on the cusp. The person who has osteopenia, who you have to do a long construct, or you're stopping at the thoracolumbar junction and you're worried, but then they have a minus 2.3 or minus 2.4, and insurance says they don't get approved for anabolics. What do you do in those situations?
I call my bone density people, the bone health people, and force them to prescribe it. And if they can't prescribe it through insurance, they give them samples. I don't know how they do it, but they get it done. Because 2.3, 2.4, 2.5 is all the same.
Yeah, I have that managed completely by my endo people. Do you guys have prescribe it yourself or no?
I want you to move on so we can.
Okay.
So what ended up happening was T10 to pelvis, PSIF with L2 to 5 laminectomy, extended Schwab type 4, L4 PSO. This is kind of how it looks like intraoperatively. This is the L4 PSO. There's lateral accessory rods used for stabilizations, and then subsequently compressed over here. And this is the final construct, 6 rods used. This is the pre-ops on the left, and on the right, post-ops, T4L1 hip axis down to 2 degrees, sagittal and coronal alignment restored. Intraoperatively, there's no pre-op, intra-op, or post-op complication, neurologically intact. 6 months, minimal back pain, significant improvement in function. Used to be on a walker, no longer on a walker. Yeah, great outcomes.
Well, can you or Mayor Tech comment on how to decide for this patient stopping at T10 versus higher?
Sure.
This is my case, and I thought that a good portion of his sagittal alignment was driven by the stenosis, but also structural, the loss of lordosis from L4 to S1. With the supine scout images, you could tell that his alignment actually was quite good. So I felt like correcting him in the lower lumbar spine with the PSO was really all he needed. I was concerned about his frailty and his, we did have him stop smoking, but most smokers restart at some point post-operatively. And I felt that extending it all the way to the upper thoracic spine from a wound healing standpoint, just overall, wouldn't be the best first step. If it came to that from PJK or a proximal issue, then we could always extend them higher. So I think we definitely could have gone higher up, but his frailty made me think maybe less is more here, at least at the beginning.
Can I make a comment? That looks great. And I think there's a difference between men and women in these patients. I think the bone in men is a little bit more sturdier, so they do better at thoracomolar junction than women. The other thing is, look at your CT scan pre-op of the thoracic spine. If there's a bunch of fused discs, it's safer to stop also. That's a trick. And then I just wanted to make a comment for you for terminology. When you use those rods, they're called satellite rods rather than accessory rods. Accessory rods connect to the main rods.
Thank you.
I want to ask Coy, MIS strategy for this with that aortic graft in the front. Would you be comfortable doing a ACR lengthening? One of the reasons I chose to shorten it was because I was concerned about the aorta and how stiff it would be from the front. What are your thoughts about messing with the anterior column in someone with this type of aorta?
And sorry, I can't see from you. 5-1 we think is fused or not?
Yeah.
Not fused, yeah. So yeah, if you wanted to pursue an MIS route here, then 5-1 ALIF, 3-4 ACR. I guess my hesitation is just with that standing pre-op film. Someone once told me the spine goes where it wants to go, and so I've had some patients before who I try to be cute and stop short, and then they just fail, and so. Sort of preemptively, my instinct would have been in an otherwise patient who's ready to go to surgery just to go all the way up. And so in those cases, I'm just going open. But like if you made the decision to stop short, then yeah, probably 5-1 ALIF, 3-4 ACR, lateral, and then perc, 10 to pulse.
All right, great. Well, I think let's move on to the next one. Mo, I think you're presenting the second case as well.
Sounds good. All right, so next case titled Anterior and Posterior Approach for De Novo Flat Back. This patient here, a lot healthier, 80-year-old male with back pain, increasingly fatigued, with difficulty standing upright at the end of the day, no leg pain, no relevant past medical surgical history, physical exam normal. PI is 42, L4 to S1 lower dose is 11, L1 S1 lower dose is 16, and then the pelvic tilt is 31, so it's trying to compensate for that. Thoracic kyphosis is 34, L1 PA 11, T4 PA 6. Supine x-rays shown over here, both lateral and AP. CT, MRI of the lumbar spine shows no remarkable stenosis, degenerative changes, multi-levels. What are your plans? Do you want to go back to the film?
So it sounds like a purely back pain problem. He has a significant amount of vacuum discs. It looks like he is quite flexible. I know that the title of the section is anterior posterior. You can certainly do a 2-level anterior is what I would do in my hands if I had to do an anterior posterior. In an 80-year-old, I don't tend to do that. Someone who doesn't have radicular symptoms, this is someone I'm probably doing no inner bodies, or maybe at most a TLIF at 5-1. And then just from positioning alone, you should be able to get your lumbar arc and your thoracic arc from positioning alone and relaxation. And you may not need significant osteotomies even to get to that realignment strategy. And it's probably someone who likely is going to go to the lower thoracic spine. I don't think I would end at L2. It looks like he has pretty significant disc degeneration at L2 and maybe even L1 there. So maybe a T10 to pelvis for this person.
I think Joe's suggestion is great. I approached this with, I think, a little bit more workup. I'm not sure if anyone else is doing this, but this guy's alignment is probably fairly reasonable for someone who's 80. And so when someone comes in with back pain and they don't have a spondy and there's multiple levels of spondylosis here, one thing I'll throw in is a CT SPECT. It's something that I try to utilize. And essentially it's a CT scan. Patients get some radiotracer and it goes to areas of the spine or the body that are metabolically active. It can be pretty useful in identifying a pain generator. You'll be surprised. Patients with all these levels of degeneration come in and it's like one disc that's lighting up, and then you just do a one level minimally invasive fusion, and they're all good. So that's probably what I would do here is one more piece of workup, and then if that was negative, then reconsider other options.
Talk to us a little bit about how you think about the low PI patient. His PI is 42. What's the ideal? Where do we need to put the lordosis? How much? Where?
Yeah, I think that's an interesting one for this one, is because Mo, what do you want their post-op pelvic tilt to be?
You want it less than 20.
Way less than 20. That you got to get that out of your head. Were you here before?
Yeah.
When you have such a low PI, your pelvic tilt should probably be under 10. I would say 10 is probably the upper limit of where I'm going to accept a PI of 40. And even then, I think you probably really want it around 7. So if your PI is 40 and my goal pelvic tilt is 7, what's my goal sacral slope?
Sorry, come again?
33, right? If my PI is 40 and my goal pelvic tilt is 7, my goal sacral slope is 33. So now I know L4 to the sacrum, I kind of want it to be around 33, and more at L5 than at L4, because if you start thinking about that Rousseli shape, this is pushing that apex caudal and more down low, and you have a reversal towards a kyphotic arc earlier the more you get down low, right? So a PI of 40, in general, the lordosis is going to be 54 total. So if we're going to get 35 below, it's 19 above, or 9 above, or 19 above, right? Yeah, 19 above. And that's how I start thinking about it. What's the goal PT? What's the goal sacral slope? What's the goal low arc? What's the total expected? And now I tell everyone, like, all of these surgeries you should be simulating. Even doing it in your head is fine, but you should be simulating them pre-op on something like, one of the commercial. I tell everyone to use Sola Spine because it's free. And now you can make custom rod templates on Sola Spine too for free. And you can give them to your fellows on Monday and say, bend all my rods, give them to CSPD. And you can but we put that up mostly for the people in countries where they don't have access to unit and key ops and things like that.
So Mike, what's this patient getting?
I like 2-level. I would look at a 2-level ALIF. I want to look at the MR a bit more to see if 2-level is going to be okay, or if it's just 1 level. I had my hand up for the 3 to the sacrum still being minimally invasive, because I think that's one of the things I really want to explore with the immunophenotyping and immunologic response to surgery. Minimally invasive, I think, will be defined by the minimized immunologic response to what we do. And I don't think a linea alba split and a retroperitoneal approach that loses very little blood is actually going to stir, or it's going to stir things up a ton by virtue of moving your bowel around and things like that. And this concept of minimally invasive is going to kind of go out the window, and we'll try to objectify it and redefine it. But I love the fact that you brought up a CT SPECT. And when you look at the literature, nuke med with CT scans, it just doesn't seem to work. Like every time ESD shows one of those, I feel like we all have trophies, right? And we all have the stuff that I'm literally never going to show you guys. And I don't want to see trophies. I don't think that CT specs have really played out in the literature when people do large swaths of patients as precise as we want it to be, and perhaps the MR spec, but I think that whatever is going around now is some version of Nocimed, right? And Nocimed was a thing when I was a resident 15 years ago, and it still hasn't really taken traction. It's just a ESMIS conversation.
I have a question for the panel. So we do see quite a bit like degen flat back patients, and I think in terms of carpentry, like you can get the correction with the A-lift, T-lift lateral. So my question is more about the UIV. So I see a lot of arguments about like stopping at the lower, upper lumbar levels. What's the pros and cons? Would you recommend to stop like in similar patients L1, L2? If not, why not? If you do, why?
My personal results at L1 are terrible. I think when I looked at mine at 4 years, I had a 75% failure rate. So I stopped doing that. So I'm either 2 is my max, and I would say that probably around 35% long term at L2. And so, he has some degeneration at 1, 2. I'm not sure how stiff it is on the CT. So, maybe it's an option. Like for me in my practice, you probably wouldn't get surgery at all, just with an 80-year-old with some back pain and a degenerative deformity. Probably, I think I have 250 people waiting for surgery. Probably wouldn't be first in line for.
How about L2?
Sorry?
If this patient's have healthy L1, L2, how about L2?
Well, I think there's enough stiffness at the 1-2 disc in the back there that.
Assume that this L2, L1, L2 disc looks like T12 L1 disc. Would you stop L2? I think the argument is, I think as an open surgeons, I have the same results. So the L1, L2 doesn't work. And a lot of like young surgeons who's inclining to do MIS surgeries, perk screws, I think the trend is like do lateral surgeries and do perk screws L1, L2 to S1. Seems like they are kind of arguing against open surgeries. The MIS surgeries works better. So that's why like, what are the pros and cons? Like, if we want to stop it shorter in the lumbar spine, what would be the criteria in your opinion? So I'm just asking your opinion.
Yeah. Do you think your MIS is going to prevent junctional problems in this guy?
That hasn't been borne out in the literature. I think when you study MIS and PJK and you control for a number of levels done, the rates of.
Can you show me the coronal plane? Is there a curve above? Yeah. I can't see it very well from here, but if there's a curve, I would go to T10 for sure. And I think my results are also very similar to Steve. Stopping at L1 or L2 is fraught with trouble. They come back. But so do the people with T10. So depends on what you want to revise, But I think it's the T10 ones, they're better because it's more rigid up there. L1, L2, T12, is very flexible. That's why all the thoracolumbar fractures happen at the thoracolumbar junction. That's what all the stress is.
I'd also be afraid a short fusion and a malaligned. If I'm not going to go crazy to line him, then I think no matter where I stop, I'm not going to be happy. So, and I think that's one of the problems. You have this degenerative. It's really hard to do with our basic screws and rods to get enough angular correction, especially at the bottom. That I think you end up setting him up for a little bit of trouble. So.
Yeah, great talking points. Thank you. So what ended up happening was a L3 to S1 A-lift with a T10 to pelvis posterior spinal fusion. This is the intraoperative X-rays, and you can see the exposure. These are the inner bodies being placed, and this is how it looks like realigned. PI 42, L4S1 35 degrees, L1S1 42 degrees. Pelvic tilt 22, thoracic kyphosis 43, L1 PA 0 degrees difference. This is the sagittal and coronal appearing alignments. Clinical outcomes, there's no pre-op, intra-op, or post-op complications. Neurologically, she was strong at baseline. 2 years post-op, pretty happy with the outcomes. No leg or back pain. Yeah.
Can you comment on your vertebroplasties at the UIV+1? Is that your standard or? I see quite a bit of that.
That is my standard for people on the older side who have documented osteoporosis. Yeah, we use fenestrated screws at the UIV at T10, and then I used to do bilateral kyphoplasties at T9, but I was concerned that may stiffen up a little bit too much. We've had adjacent segment fractures, so now we're doing it on one side. There's some literature to suggest that more than 4 cc's of cement in the body stiffens it up to the point where it risks the adjacent level fracturing.
I think that I'll be curious to see sort of long-term for these type of cases that have good back pain relief from all the instrumentation. Just because a number that jumps out to me, again, I think Mike harped on it earlier, is the pelvic tilt. This patient has to have a retroverted pelvis right now just to compensate for how much upper lumbar lordosis there is. So I just don't know, long-term how well the back pain would potentially last, but.
Yeah, my critique of this is there's probably was not a need to do the L3-4 ALIF. I think that put the lordosis a little bit too proximal. I think 4-1, or even like Mike said, 5-1 probably would have been sufficient. We were actually shooting mainly to correct his pelvic tilt. It was 31 pre-op, and the best way to do that is to restore the distal lumbar lordosis. And I think here we probably kicked it a little bit too high. It's good to be critical, and just so.
I think that the thoracolumbar junction in general is very difficult. And I think that is one area, like now in peds, right? That is an area that is oftentimes fused in pediatrics. And I'll give it, because it's most of us here, I'll give it a they. They don't get it. And Peter teaches our fellows T10 to L2 flat. When you make the thoracolumbar junction flat, it's like squeezing out a tube of toothpaste. And you're going to put all that kyphosis above and all the lordosis below, and it doesn't work right. And really reshaping it into, and Gupta calls it the game of arches, into 2 arcs rather than an arc connected by a line, connected by an arc, is very difficult. And I was telling Justin Shear earlier, like, it's nice to numberify all of this, but you have to experience it a little bit. And you were there, like, the WashU way used to be, I would make an arc at the bottom, and then I would cantilever the hell out of it, and then I would make an arc at the top. And their C7 SVA would be good, but the outcomes weren't good. We had PJKs. We had magnificent radiographs where we'd show the patient who was complaining about how much their back hurt, like, look at your x-rays, that's freaking awesome, but you're not doing well. And that's not a natural pathway. In part because when you do it that way, you can, and this is where the complex, this is where the next place that the VPAs need to go, is because you may make a shape like that achieves all of the VPA targets, but because the arcs are wrong, the slopes are wrong. And for the math nerds, that's all the normals to the first derivatives at each level is the slope. And we really need to figure out, this is the target I'm making, and this is the L1 slope. Because if then we can say the centroid needs to be here and it needs to be tilted like this, then we can make very precise alignments.
Any other comments, questions? No? All right. We can get the last slide, the next slide.
On the positive note, look at the lordosis you were able to get at 4.5 and 5.1. And that's because there was air in there. So when you have air, you should celebrate. And because that will open up, there's some motion there. You didn't need your 3-4, as you said. Yeah.
All right.
You do 2 approaches or one? 2 stages?
Same day.
No, but is it 2 approaches for the 3-4? Did you need a set? No.
No, single, paramedian incision. All right, thank you, Mo. We can bring up the next slides. And our other fellow this year, she's a neurosurgeon coming to us from Mongolia and University of Chicago, Anu.
Are they going to explain the corona radiata and all that stuff to the orthopods? I'm just kidding.
Central gyrus. It sounds bad.
Yeah, I forgot about it already. We're gonna do a flat back after short segment on this one. How does it go forward? Maybe here. Oh, I see. Okay, this is a 63-year-old female with a prior short segment posterior fusion with the TLIF presenting with back pain and a leg pain that has been going on for several years after the prior lumbar surgery. No, hold on. Her past medical history is noted for hyperlipidemia and obesity with a BMI of 32. Otherwise, no other major medical problems. Her surgical history is noted for L3 to 5 posterior spinal fusion with TLIFs, as well as a left-sided L5 S1 decompression and uterine fibroid surgery and an appendectomy. On exam, she doesn't have any neurological deficit. Preoperative parameters included PI of 53, L1 S1 lumbar lordosis of 29, PI LL mismatch of 24, L4 S1 lumbar lordosis of 17, PT of 30, thoracic kyphosis of 26, L1 PA of 14, and T4 PA of 6. And the CT lumbar spine showed the previous post-surgical changes and union at L3 and 4, L4 and L5. And the MRI lumbar spine showed adjacent segment degeneration below the prior constructions and correlating with her symptoms. Plan.
So who knows what kind of instrumentation this is? Can you go back to the AP? Is there an AP here?
I don't think so. Oh, yeah.
It almost looks like a Zilke kind of rod, doesn't it? My first study ever when I was a fellow was on Zilke rods anteriorly. There was a 21% failure rate for anterior scoliosis. It was a very thin threaded rod. I don't know if this is what it is, but it does. I can't see it very well from here. So we know one of the problems that we need to solve, and we've been talking about it, is when you get an X-ray from wherever and you don't know what it is, none of the universal removal sets work that well. It's always a pain. So we need to solve that as surgeons and industry folks like Eric. Right, Eric? So anyway, that was. I just wanted to bring that out. It's a pain we have to solve.
I'll get the surgical plan started. So, to your point, fused rather flat, degenerated above and below. With those disc spaces, there are opportunities for lordosis restoration. I do worry about kind of how flat the segment is from 3 to 5, but at least in my hands, this would be a 5-1 ALIF, kind of as much lordosis as we could get, and then a prone lateral approach for an interbody placement at 2-3, and then just re-instrument, L2 to S1 or S2, dealer's choice there.
I actually think this is one of those ones where that would potentially work. I worry with the high PI patient who has this much pelvic tilt to start off with, whether or not the ALIF will fully get you there or not. So this might be one of the ones that I would consider doing an ALIF at 5-1 and doing a small PSO at L4 and then doing an L2 to pelvis. They actually would probably do really well from a realignment strategy. The longer you go without correcting that iatrogenic flattening, it may go on to bite you in the future. And really, that's where the deformity's at.
I was going to say, I don't know if you'd be able to get an ALIF with appendectomy and uterine fibroid surgery. So I would do a TLIF, and I would begin, I didn't understand the small PSO that the French talk about until I started really getting in the weeds. And this is probably one, too, where you don't actually even need to take the whole pedicle. You can do that sort of pedicle slice, and you leave the caudal aspect of the pedicle at L4. as a nerve retractor, and you get 15 degrees out of that instead of 45. It kind of protects you from overcooking it too.
So what do we think about the thoracolumbar lordotic junction there? Is it structural? Can go back to the imaging? Is there any? I didn't really see a lot of imaging on. Because whether that's a compensatory compensation or whether that's a structural deformity would change a lot of where we pick our top level. But it definitely is abnormal, so that's something I would look a little closer on my CTs and MRs to see what I'm dealing with. And that would change my UAV from either extending from just extending down to the bottom versus going up a little higher.
What are the patient's symptoms? I missed those. Is it like they can't stand up straight?
It's a back pain, yeah, significant back pain and leg pain, both going down her legs.
Do we know where the back pain's coming from?
Do I? Presumably from the alignment issues as well as the adjacent segment degenerations.
Shane is bringing up a good point. When you see these patients and they have a lot of axial symptoms, you would expect when they lie down, the axial pain goes away, back pain goes away. This patient has a lot of back pain when she's lying down. Guess what? After you do a reconstruction, she's still going to have back pain and be not happy. So I think that's what you're referring to. Is that you got to know, is this I stand up and my back really starts to hurt, or is it, like I lie down and it all goes away? Usually the patient like this is asymptomatic when they're lying down, a good reconstruction will help.
So, this is a very seductive case because you can do an ALIF at 5'1" and just extend her above, but then she'll be back again. So this is one of those where it goes round and round and round, and then ultimately somebody has to do a PSO to get the reciprocal changes above fixed, because the thoracolumbar junction is lordotic. The apex of the lordosis is in the wrong place. You need to bring that lower in the lumbar spine with a PSO. So
what's your time frame for the patient that you're willing to accept before you do it? Is it 1 year, 2 years, 5 years, ever? Well, so in the world of spine surgery, obviously you go with adjacent segment disease, whether we go to T3 to the pelvis or C2 to the pelvis.
Mm-hmm.
So if you're saying to the patient, hey, you're going to be good for about 2 years, is that? And I'm asking, I'm just like for discussion, or are you 5 years?
So I think there's no time really. I think the patient will tell you. And I tell them that if the pain is every day, you can't live with it, you can't function, they need to get it changed. So if they have a poorly done job, they're going to come much quicker. But if they have a good job, then it will take 4, 5, 6, 7 years for it to degenerate if it's lined up properly. It may not stop the degeneration, but the revision's a lot easier because now you don't have to do the realignment and the extension.
So devil's advocate here. So let's say you injected the 5-1 facet, pain went away. Or let's say you injected the 2-3 facet and the pain went away completely. How would you?
I lean forward to revising it and realigning it because I think that long-term has a better result, because I think if I just do 5-1 and it's still flat, the 2-3 is at more risk than if I were not to realign. So I take I guess I've been burnt too many times and I revise too many patients to just go do the right alignment in the first case, even though it's harder. Do the right thing even if it's harder.
All right, so here's a question for the group then. So let's say you do 5-1 and you expect 2 to 3 years before the patient comes back versus going to T3, realigning. What do you expect before the patient comes back after that?
Yeah, I agree with Dr. Gupta. He just said he wouldn't go to T3.
I'm just saying, like, taking
like
control. So all right, T10. So you get, or L2. You
Yeah,
get adjacent
L2 with
segment
the
disease.
PSO versus ALIF only, right?
Yeah.
ALIF, PSO versus ALIF only. But you're just saying big surgery versus
The
small
point I'm
surgery,
trying to
right?
make is that
And I would say that 2 years is not, I don't think that's good. If I were the patient, I would think that sucks. And if it comes into my clinic and I'm revising you 2 years after I just did it, I'm not going to be satisfied with myself.
right.
You're bringing up a really,
So-
you're both
so
bringing up a really good
nobody
point.
is, but the data when we stop at T10 or even T3, we revise a lot of people.
Yeah, I think you're getting at, I think, the difference in philosophies from some of us that spend more time in the deformity world versus some people that spend more time in the degen world. Like if you ask my degen partners, 2 years of a younger person who's very active, who gets their activity back, is a great outcome. But then the deformity surgeon who's having to do kind of more work after 2 or 3 surgeries, we sort of look at it like it should have just been fixed up front. And I think there's a divide between how some of us look at that.
From a degenerative person standpoint, it'd be extremely hard to convince somebody to get a big surgery, at least in California. You know, we find patients will come to us after being recommended such an enormous operation, and all they want to do is go back to some of their standard life. And even if they are getting a little bit worse after 2 years, they don't, then you say, well, you probably need a big operation. And then until they're absolutely miserable, they can't walk around at all, they don't go for that big operation. They go for anything small that they can get. And that's been the mindset, at least for a lot of the patients that I've seen that come after. They may need that. You know, in an ideal world, you'd say, okay, this is what you really need. But how do you convince a patient that they need such a big ass operation?
And I don't think it's about convincing per se. I think it's having that full-on discussion. You might have this person be like the engineer who you can have maybe a high level, or a physician, you have a high level discussion and they go for the bigger case. I think ultimately it's going to be, how do we evaluate what was the right path? Because in my hands, I'm probably passing off that patient you're referring to that's in San Diego, who maybe got convinced to do the 1-level surgery and they're happy for a couple of years. How do we as a group, both degenerative deformity surgeons, look at these cases 10, 20 years later? Does the person who had the 3 or 4 surgeries, do they live with regret? They should have signed up for that bigger surgery? And is the same true for the deformity patient? Are they happier, or do they also have regret because the recovery took them longer? I don't think we know the answer to that.
Yeah.
But you're right that those patients are there, and that discussion, whether you're convincing them or you're allowing them to let them choose that choice of which path they're going to take, it's difficult.
Because when you have that discussion, you're also having a huge discussion about the potential for complication that can be significant in spinal deformity reconstruction. And that's why the MIS stuff becomes so much more popular, right? People are constantly looking for MIS approaches for that because they don't want, they look at the complication profile, and if you're trying to be honest with the patient, you have to tell them all about that complication, right? But so Manish, you know, you're such a really phenomenal surgeon, and you know, it's like you probably have fairly low complication rate. But for the normal individual that's trying to do this, say for instance myself, that's going to take twice as long to do the operation as you. How do I actually give them away, right? Because I don't think I'm doing the patient any justice. But that's not necessarily available to most people. So do you go after it yourself, or do you know, if you're like a normal, ordinary surgeon?
Well, I think you're giving me too much credit, but I have to say that I have complications just like everybody else. And I think from what I've learned is do the right thing as much as possible. There's no right or wrong answer. And I think Dr. Osorio pointed out, having that discussion very clear with risks. Because of that lordotic thoracolumbar junction, they keep coming back because the alignment is not proper. So I think that if you have an honest discussion with the patient and yourself, and if you think that, you know, in my hands, the risks are a little bit higher, and I have a friend who can do it better, you know, that might be the best thing, because there's plenty of cases. You still have plenty of cases. So I think if you want to pass it on, there's nothing that will make you look better than getting the right thing for that patient. That's what they want. And I think Shane had a great point about the 2-year, 5-year, all that. Yeah, we've seen all that, but we've also learned over time which ones continue to fail and which ones don't. The ones that are aligned properly, they will still degenerate, but it's much easier to revise. The ones that are not aligned properly, they need even bigger and worse operations and extensions. That's my goal, actually.
The biggest problem is at the end of the day, even on a perfectly aligned patient, we can't prove that their outcome's going to be any better, and we don't have the data for that. And then, like, we plugged in the L1PA in our data, our T10 to pelvises, and we couldn't notice a difference between ones who were balanced and unbalanced in terms of our PJK rates on our personal series of about 150 cases. And so,
But if they get like a neurologic injury, skeletal palsy, their quad doesn't work, they get numb in the feet, they get a DVT.
I'm just looking at PJK
right?
mechanical. I
Right?
agree.
All those other
But you
medical.
can get that with an MIS surgery as well. So, nerve root injuries, and that's why part of the data, all the ISSH data is based on ODI and outcome data, which obviously doesn't include whether you have a nerve injury, because alignment is one component of outcome, as we all know. So there's fusion, there's neurologic injury, there's a lot of other things. But at the end of the day, I have a guy who's in his low 60s with a small degenerative curve with a lot of back pain, and I think doing anything small on him might be back for more. I've been talking about a surgery because I don't think a T10 to pelvis is warranted for a guy who wants some MIS exactly like the way you say, but I don't think the MIS is going to be helpful for the guy. So, but I can tell you that we're all going to have junctional failures. The mechanics is there. Fusing is an unnatural thing. But I agree with Manisha. They're going to come to us. We're going to do the best we can for them, and then play the odds on that end. So. I always say you don't need the first surgery, but you need all the other ones after. So.
She ended up getting a removal of hardware from L3 to 5, revision, T10 to pelvis, L5 S1 taillift, and L4 PSO. And this is the images post-operatively and post-op measurements were PI 53, L1 S1 lumbar lordosis 63, PIL mismatch of 10, L4 S1 lumbar lordosis 54, PT of 19, thoracic kyphosis of 43, L1 PA of 7, and T4 PA of 3.
So I saw her in clinic. Yeah. So I saw her in clinic this past Tuesday, and she has no back pain, leg pain's gone. And I was going to share this with the group. Shane, you and I are huge believers in these multi-rod constructs, not just from a rod, prevention of rod failures, but I think it improves their stability. And it's crazy. You'll see 6 weeks, and this is consistent now, 0 out of 10 back pain with multi-rod. Chris, Vidat, others in the group, do you guys notice this with these multi-rod constructs? I think it...
We anecdotally were talking to each other. This is many years ago. I can't remember when we started doing that, but yeah, that they just did better faster. There's something about the stability of the lumbosacral junction and pelvis. They definitely do better. I agree.
And to clarify, because I know there's data showing 4, 5, 6. Is multi-rod even doing some of the 6 that I've been seeing in some of the X-rays?
More than 2 is multi.
Just more than 1 is multi.
I think what he's referring to is, correct me if I'm wrong, double pelvis rod, rods, separate rods going into pelvis. That's what we.
I have a question. I really like the open conversation. There's not a lot of meetings where you can have an open conversation like this. So I have a question. I saw some of the x-rays with SI joint fusion, okay? I want to bring that up because I think there's a lot of that going on, and whoever did it or who has some experience, I want to know how the patients are doing. Is that different than the dual rod construct to the pelvis? So if you have one rod to the pelvis and an SI joint fusion versus two rods to the pelvis, is there a difference? Anybody have an idea? Because I think more of this is going to come out.
I'll comment a little bit about that. There's a lot of focus, obviously, on proximal junctional issues. And when I was on the ISSG with Bob Easlak, we looked through everybody's, constructs. Actually found that the distal failure rate of loosening screws or broken rods at S1 or set screw pop out was actually like 25 or 30%. Right? And so not all of those patients need revision, but a fair amount do. And at least the thought process in my mind is that it's because even though you're putting in these huge screws into the S2AI or into the pelvis, in and of themselves, they're not, arthrodesis, right? And so actually every T10 or T4 to pelvis that I do, I'm doing the supplemental SI joint fusion. And I don't have a huge deformity practice, like not every day for me, but I think I've done maybe 60 of those. And I think only one or two has come back with loosening. So, much less than 20 or 30%. That's my thought process.
I don't have the comparison between 4 rods and 4 points of pelvic fixation compared to like 2. But in my practice, I evolved from doing 2 just solid state metal screws to now I'll end, if I'm doing like a T10 to pelvis and there's only 2 screws, I am using the SI joint fusion type screws. And what I've noticed over time is that patients usually at the 2-year mark will start getting some of that distal pain if they look like they're aligned well, their pelvic tilt compensation did really well. But with the non-fusion devices, those screws would loosen over time once that fusion at the lumbosacral junction, I feel like, solidifies. And I'm having to, and although that rate in my practice was probably a little bit higher than it is now, I'm not having to take those patients back. I'm not hearing about that distal pain. Maybe they're getting more hip surgery, but they're not. I think it is helping.
Yeah, I've switched to doing primary SI fusions on all my. I do, if I can, an iliac S2I and an iliac, and I clean out the joint directly, and I take bone. So I like to use a dual-headed screw in S1, so I have to take out the lateral pelvis anyways, and I shove that in the SI. So I have direct bone fusion, and I'll see if that, it didn't make sense. You try to fuse everything except you don't fuse the SI joints.
So what I'm hearing is basically there's a consensus that a single pelvic fixation with single each rod is not sufficient. Am I hearing?
So
either we do
yeah.
dual pelvic fixation, multiple rods, or single pelvic fixation with SI joint fusion. Seems like the panel is like something additional needs to be done with the single pelvic fixation.
Well, I looked at all my the last 260 T10 to pelvis that I personally had, and we had 50 broken rods.
I mean, for last 8 to 10 years, we've been doing
With one level, one rod on each.
And I think one of the questions stations on one of my patients, the pelvic fixation, even though the pelvic fixation failed because of the large SI joints, I think we worked with the CT scan. They had a really mobile, like a lot of parts pushing the SI joints. Those patients were benefit from SI joint fusion. Either like barrel SI joint fusions, or you can go drill into the SI joint from posterior with some bone graft. So it's very rare that the fixation fails only to do fixation.
There was a presentation at SRS actually that demonstrated, I think, a 10% development of new SI joint pain through their follow-up, which was at least 2 years. So that was. Normally, I hadn't done that. I typically put in multiple pelvic fixation, multiple rods, but more recently, based off of that data, I've started adding SI joint fusion to my constructs as well.
Is that because of the single pelvic fixation? Is that patient with dual pelvic fixation?
So in that data set, I don't know, actually. I don't remember.
Like, at least 20% pelvic discomfort, iliac screw discomfort when we were doing bone construction single pelvic fixation. So that rate was high. So 10% seems like can go a bit higher than we do about real pelvic
I think the data that Pauly has presented and the data from the ISSG is not compelling for prophylactic SI joint fusion. A rate of 10% is the number needed to treat. That's going to be pretty large. I think every time Pauly shows me stuff and says the SI joint needs to be fused, the iliac screws have failed at the tulip head and the rods are out or the set screws have wiggled out. That's a sagittal plane problem. It's not an SI joint problem, it's a sagittal plane problem.
A lot of them don't have S1 pedicle screws either.
Well, that's the worst. Sometimes the PEDS people do that all the time. It makes me mental when I see that. The SI joint is not a cause of sagittal plane malalignment and having the screws pop off the heads and stuff like that. The fact that they loosen and wiggle and become symptomatic in some small proportion of patients when the lumbosacral junction is fused, that's real. But I would say the number of screws I see that are windshield wipering and totally asymptomatic don't compel me to, Seth, you left again, to use $4,000 screws on everybody and add more billing charges to my cases. It's not for me.
I think one of the things that coming our way is that you're going to see a lot of people and patients with the key to SI.
Oh, yeah.
And then there's going to be a cross struggle.
Yeah, let me make a comment on that. So you know, these patients come with those 3 screws on both sides, and then you don't have any corridor to put your screws unless you navigate very carefully. But I have actually removed them and then done the screws, and that works.
Do you have open removal or like they are usually put?
Yeah, I know, but what I do is I sneak over the crest, make a stab incision, put the screwdriver.
You open up the crest like you used to do.
Yeah, exactly.
Do you make a new incision, or do you use their old, because they use like MIS incision, do you use that one, or you actually just go over?
No.
He's opening the whole thing.
I'm doing the back revision, PSO, all that stuff, so it's open anyway. So you just go over the iliac crest, and you find the tip of the thing, and then the fellow finds the screwdriver, takes it out.
So one thing I realized on that one, I think when you dissect the glute muscles that far, that creates a significant dead space. I think those patients, that, you know, when there's the data about the infection, when you go down to the sacrum, there are high risk of infections. I think that infection is related to dissecting that much muscle from the pelvis. Not necessarily just going down to the pelvis. So,
right. What I do is I go around that channel right above the greater sciatic notch. So I don't like fillet the whole thing. It's just a cob size dissection down, put a talar retractor, you find the tip, and then. So if you dissect the whole thing, yes, a lot of dead space, a lot of scarring, a lot of pain, the gluteus. Yes, you're correct.
No, but we begin to take him them out. Yeah.
I think the infection's from coverage, not from coverage. They poo on their backs. And that's why they get infected. It's all gram-negatives and Enterococcus fecalis. It's not staph. And it's all because the wounds are right down next to the crack. And that's, you need barrier dressings. That's what you need. And the worst is those Prevena things that suck the poo right into your wound.
Code Brown.
Yes. Oh, okay, on that note, last case before lunch, it's going to be a persistent flat back after a prior lumbar PSO. This gentleman, 72-year-old male, lives in Hawaii, very relatively active. Gentleman still works, presents with back pain, difficulty standing upright, limited ADLs, very, very healthy. And you can see his past surgical here on the bottom, all done in Hawaii. 2019 had a T11 to L4 anterior open retroperitoneal fusion release from the left, and then a T4 to the pelvis with L5 laminectomy and L5S1 TLIF. And then about a year later-ish, a year and a half, underwent a revision T4 to the pelvis with an L3 PSO. And these are his presenting radiographs. You can see broken instrumentation in the pelvis, as Mike was saying. Tulip head popped off, set screw displaced, rod fracture. And pretty significant iatrogenic flat back deformity. Laying supine, again, the SVA C7S1 corrects, so he's balanced, but he's got a regional lumbopelvic mismatch from the flat back, huge pelvic tilt, his sacrum is vertical, and you can see the T-lift cage here is not united, has a very noticeable non-union at 5-1. The prior PSO site, so L5-4-3, I wouldn't call that a PSO. That's just a little cut in the bone. Yeah. And he's fused in the back at 4-5. The disc is open at 4-5. So L5-S1 union, L3 PSO. So I'll open it up to the group. What do you guys think? What would you do? So large shark bite on the left, anterior exposure down to L4, L3 PSO is persistent flat back.
I mean, I look at it closely, but I think most of your deformity corrections should be isolated to down to the bottom there at 4-5, 5-1. So I think this would be a good one to either do an S1 PSO or an anterior 4-5, 5-1 LF. So with some big, I'm just not sure how much end plate you can. I'll defer to you guys. Once you lost end plate, how much correction can you get through an ALIF with the bone loss on the inferior end plate of L5? So.
Mike?
I don't know if you're going to get to 4-5 with the prior. I don't even understand the anterior. There's barely anything anteriorly. But if you can get a contralateral approach to 5-1, I'd do a 5-1 ALIF and then do a L4 PSO.
L4, L5?
I would do a 5-1 ALIF and then do a 4 PSO. A 5 PSO here is hard because there's nothing left. That's why, like that last, you got to look at L5 before you decide you're going to do an L5 PSO. Sometimes the geometry of L5 stinks. The last one with the block, right, the 4-5 block had a very nice, fat, long anterior column, which with the La Martina, I try to either preserve or even crack it a little bit to lengthen the anterior column. But when it's too short, you're not going to lengthen the anterior column, shorten the posterior column. That's how you're going to do a PSO, and you're going to end up with the same thing, right? You're going to do a PSO, it's a big surgery, that's still undercorrected by 20 or 30 degrees. You need to get a big correction out of this to get it right.
Okay. Good question. I don't know. It's 50, mid-50s. It's not low, it's not high. I think he's middle of the road.
When I look at this case, especially the standing radiograph, I agree with Mike. I would like to try to see if you can do a 5-1 ALIF and a PSO on this patient. Unfortunately, because they're fused so many levels inappropriately, I feel like that toothpaste description that he described, you're going to probably be able to realign sagittally the patient with all that work done at the bottom, but you're going to fail probably again at the top because it's going to have to reciprocate to some degree from that entire flat region proximally.
I do Smith Pete through those.
Yeah, that's what I was going to say. So I think the one thing that you would want to do is look at the CT scan. This person probably is not fused at all of those levels. Wherever there's no fusion through the disc space, a Smith Pete through there to try to get some more harmony through that entire flat region may help that future failure proximally.
And do you happen to have their x-rays from before any of the surgeries? Because this looks a lot like someone who, when you do, scoliosis is 3D, right? And there are 3 planes, and you can dominate one plane, you can control one plane, and one plane you got to kind of let fly in the breeze. And this reeks of someone that had like 70 and 70 degree curves, and they use coronal benders to dominate the coronal plane, and all that does is flatten it out and totally screw it up. And then it's, like to their point, it's really hard to fix. And you really got to try to dominate the sagittal plane and get apical translation, but leave some hanging out there for the sake of getting the sagittal right, because you don't really fail in the coronal plane. Yeah, there's a scoli there because you can see all the rotation.
I don't have it.
So
I think my approach is not that much different from everybody else, but I would do the back first. I would take everything out in the back and do adjacent PSO at L4. So you'll have not only like 2 nerve roots, but 3 nerve roots in one foramen. So you do a L4 PSO, and really you might need like 4 iliac, S2AI, whatever. Get all that lined up first. And once that's lined up, then go in the front, ALIF, and then pack it with whatever cage or I use femoral ring with BMP, whatever you can, because when you do that from the front and then do the back, things are going to be moving, and then you're doing the PSO. This way you dial in your lordosis, and then all you're doing is providing structural support and getting fusion in the front at 5-1, which is super important because all the kyphosis is at the lumbosacral junction. Mm-hmm. And if you don't restore the anterior column, it's going to not heal, at least from what I see. Not so often. In fact, I'm giving a talk tomorrow on this. Mm-hmm. So I'll show you a case very similar to this.
Manish, with a prior anterior on the left going down to L4, would you go back to the left or would you go on the right?
I would go fan and steel.
Okay.
The other tip I can give you is get urethral stents from the friendly urologists. They put it in, they put the stents in, you do a fan and steel and go straight in. Don't go with the sides or anything. And go straight in, you can find it. And then do it, and then get out. And then they pull the stents out right after surgery.
Okay.
What I found for these cases is that the vascular surgeon, when they do a fan and steel, if they choose to go from one side and it's really stuck down, it gives you the option of going from the other side through the same incision.
That's a great point. Comments from the audience? Bharat?
So I think Shane's question is very valid on this patient. So if the patients have really, really high pelvic incidence, I think the S1 PSO might work better for this patient because I'm worried about the 5-1 disc might be just not the zero. There might be also some infection, amount of bone damages that is kind of concerning to me that you might want to remove that cage and debride the disc. And if you do S1 PSO, that might work. But I really look at because also if you look at the AP, patient is really rotating the pelvis to compensate. If you look at like AP view of the pelvis, so I think the mismatch is like significantly more than 30 degrees. So the S1 PSO will benefit, but I wouldn't do it unless the PI is really, really high. If there's a high PI, I think the S1 PSO would work really well. I really still believe that you need to debride that disc, either anterior or posteriorly. But in terms of like technical challenging of the PSO, I think the L4 PSO might work better. L5 PSO, then you might have infected pseudo 5, then you're creating the osteotomy, then all of a sudden like you don't have any L5 vertebral body, then it's going to be catastrophe in terms of creating the construct. So I think I would go between the two options, either the S1 PSO or L4 PSO with anterior 5-1 debridement and cage removal.
And would you do the back first and then the front? Or?
No, I think I would debride the first to 5-1 with the ALIF if it is accessible. And sometimes the vascular surgeon like, hey, it's too scarred, I can't. Then you do everything from the back. Since there's so much implant fracture there, I don't think that you need to take everything out to see how mobile it is. But I think debriding the 5-1 is going to be really important.
Okay, great. So what we had planned on doing is very similar to what everyone's discussed here. I didn't want to deal with the left side at all. The fan and steel incision would have been nice to have the option of going left or right. So we did a right-sided paramedian approach, took out the T-lift cage, debrided it, took cultures. They subsequently did grow C. acnes or something of the sort. And then the second was we did a revision, just the lower lumbar spine. And I chose to do an L5 PSO, mainly just to stay out of the scar tissue at the prior L3-4. And if you do an L4 PSO, you can take off the facets at 4-5, then the disc is open in the front. So you're going to do a T-lift there. That would have been another option. But I just thought do an extended L5 PSO, take out the disc, put some bone graft in there, and try to achieve all the correction distally. So these are just some of the intra-op, very large space. I think this is important to have implants and instrumentation that would fill the space. So standard 15, 20 degree ALIF cage is going to be wiggling in the breeze here. So we ended up using a 30 degree hyperlordotic just to fit the space and to get a little bit more correction. You can see the rods posteriorly have a little bit more lordosis to them compared to where it started
Did you
on
think
the
about
side.
fixing it to S1 only so that when you put her prone, you get a little bit more lordosis at 5'1"?
I did. I just wanted to, yeah, we could have done that too. Yeah. And then here, what we did is instead of exposing everything, we just cut the rods at 4.5 and took advantage of the prior rod failure and dual pelvic fixation, and then just connected up to the old instrumentation. We used the lateral accessory rods, so these are connecting to the main rod, and essentially used that as our stabilizing rod for the PSO and just used that as our a rail as a compression technique. So from 4 to 1, we measured out, we got 50 degrees distally, and I had dinner with him in Hawaii. He's been 2 years out, and he's happy as a clam. So I think he's doing well so far.
How did you decide sort of how much of a L5 PSO to do?
Good question. I took out the disc and took out the pedicles. We put the screw in there, but I did a standard amount of wedge.
You know, on the AP X-ray, you can really see the pelvis, see how retroverted it was, and now it's more normal. That really tells you the story. It's a good job.
Thanks. Okay, I think it's lunchtime unless there's any other comments. This guy, no, but
He'll be back.
it's coming. Yep, it's coming. All right, thank you, everybody.